My topic is something which will evoke some questions and also some doubts and some debate. But it is a topic which is very close to our heart, and I'll show you the reasons. Um, Pre-diabetes is pathological and highly prevalent in India. That is something which is known for quite some time.
With the picture.
Now, what is pre-diabetes? Just to recapitulate, either fasting sugar or post glucose, blood glucose is taken. A fasting blood glucose between 100 to 125 is called impaired fasting glucose, and post 75 gram glucose between 140 to 199 is called impaired glucose tolerance. Both together are called pre-diabetes. It is also classified by hemoglobin A1C between 5.7 to 6.4, which is an imperfect measure of pre-diabetes. And in all my patients, I use oral glucose tolerance test to classify people into IFG, IGT, or both together. There is no doubt that pre-diabetes leads to increased risk for cardiovascular disease. And as has been shown in this particular slide, this is the old slide of 2002 study, which shows that risk for cardiovascular disease is already high when the person is diagnosed to be pre-diabetic, IGT here, more than normal and less than patient with newly diagnosed diabetes. Now, this is the kind of thing that we are seeing in India. This is the article, Prevalence and Trends of Diabetes Epidemic in Urban and Rural India, a pooled systematic review and meta-analysis of 1.7 million adults. Recently published, it shows rising trend of diabetes on the top panel and pre-diabetes in India. What is important to know is the rising trend. And second, it is important to know, as far as pre-diabetes is concerned, that the graph for urban area and rural area have merged together, and that rural area pre-diabetes is rising faster than urban area. Overall prevalence in 2017 was 10.3% according to ICMR India study. Now, prevention of pre-diabetes so that it does not progress to diabetes. There are a number of studies, but there is no study which comes even close to diabetes prevention program. A 4-year study of 3,234 adults where placebo was compared to metformin and lifestyle, and a cumulative incidence of diabetes was shown to be remarkably less with lifestyle intervention. This is a path-breaking study which has been followed by several other studies all throughout the world. And this study was extended subsequently to 15 years. After 4 years, the control trial was opened up, and all three arms, people in all three arms were sent back to their general practitioners. And you can see over 15 years what has happened in this extension study called DPPR study, where the lifestyle still led to best results, but metformin over years 11, 12, 13, 14, and 15 is coming closer to lifestyle. And this was published in Lancet in 2015, and I wrote the editorial for this, and which included some of the questions I'm going to raise in subsequent presentation. This is the Indian study, Dr. Ramchandran's seminal study, where the arms, lifestyle metformin and lifestyle metformin, were compared with controls, and it was shown that all three arms were similar. The dose of metformin was lower in this particular study than what has been used in DPP4. Now, emerging questions are, which factors hinder reversal from prediabetes to normal glucose regulation? What are these factors? And if we face such situation, should we be aggressive in application of lifestyle drug? And this is very important as far as Indian population is concerned. So let's look at some of the factors. One of the first factor is ethnicity, and Asian Indians being the central point of all ethnic groups. And if you look at this excellent diagram from Sattar in Lancet in 2015, it shows the rising curve from normoglycemia to diabetes in the Asian Indians in UK and versus the white Caucasian. And this graph is so good, so separated from each other. Progression to diabetes is 12 to 18% per year in Asian Indians versus 5 to 11% in white Caucasians. And if we apply the lifestyle modification, then it is reduced by 30% in Asian Indians and by 50% in whites. So the progression is more, and reduction to normal glucose regulation is much less in Asian Indians. And so diabetes is earlier by 5 to 10 years in South Asia. And this very clearly demonstrates the differences between Asian Indians and South Asians. Age is the next factor. And this has been very, very clearly shown in the DPP4 study. If you look at the three age groups, 25 to 44, 45 to 59, and more than 60 years, and comparison of lifestyle with metformin and placebo, there are clear points which have been raised in the age group more than 60 years. One thing is that the lifestyle works better in people with more than 60 years of age, in this particular study and in this particular ethnic group. And metformin works a little less as far as this age group. So these are two lessons from this particular. So age is something we have to keep in mind whenever we are applying either lifestyle or metformin. Now, non-obese individuals are a particular subgroup of individuals that we often see in India as having diabetes. And you can see there are a number of studies. I have taken one particular study where Indians' BMI and development of diabetes has been compared to Japanese, Maltese, Europeans, and Chinese. And if we could look at the BMI between 17, 18 to 23, you see the men and women, both Indians, have a very high prevalence of diabetes as compared to the other. So in non-obese people, Indian people, diabetes is already rising. Now, what is the implication for that? In non-obese people, the beta cell mass is also less. This is an old study, but very good study, which has compared beta cell mass between the two groups of individuals, obese and lean. And you can see beta cell mass in non-diabetic people who are obese is much higher than non-diabetic people who are lean. We'll come to this beta cell mass again in subsequent discussion, so this is not the end of it. Early remission of prediabetes. Now, suppose we apply the lifestyle factors very aggressively. If somebody remits very early, this is the data, very clear data, which has been published in Lancet in 2012. The DPPO study, which I was mentioning earlier, where people who never reached normal glucose regulation versus people who reached normal glucose regulation at least once during the 4 years in DPPP were compared. The moment somebody reaches the normal glucose regulation and as early as possible, then their chances of getting diabetes is much lower. Now, a topic which is center to my heart, liver is the center of the metabolism, predicts diabetes and impedes regression to normal glucose regulation. This is our data, a very simplified form. It shows that if liver span, at that time, 2015, we did not do the MRI proton fraction, which we are doing now. At that time, we did the liver span, which is a fair indicator of the fat in the liver. This is the normal liver with the liver span of 11 centimeter, and this is the liver, which is full of fat, maybe grade 3 fat, with a liver span of 22.8 centimeter. We did a study where we predicted that if liver span cutoff is at 15.6. If more than that, if anybody has liver span more than that, chances of getting diabetes is at least 4 times higher. So liver is a problem as far as Indians are concerned because liver fat is far higher in Indians than the Western population. Now, this group, Stefan, published in 2015 in Diabetologia, compared two groups of people, high risk phenotype and low risk phenotype. High risk phenotype, what was it? Insulin resistance plus non alcoholic fatty liver disease. 9 months of lifestyle intervention, and look what happened to the fat loss and postprandial blood glucose, which is much less affected than the low risk phenotype, meaning thereby low risk phenotype had higher fat loss and higher decrease in PP glucose and revert to normal glucose tolerance was much lower in high risk. So something is happening when the person has non-alcoholic fatty liver disease as well as insulin resistance. And this group has been working on this, and next 5 years they extended their observation and published this study in Diabetologia again 2021. And they now have 6 groups. Low risk group, very low risk group, beta cell failure group, low risk obese group, high risk insulin resistant fatty liver. This was the group which I showed you in the earlier slide. And another group, high risk visceral fat nephropathy group. Now, they did insulin sensitivity, insulin secretion, glycemia, and other features. There's 3 groups that stood out. Beta cell failure group, high risk insulin resistance fatty liver group, and high risk visceral fat nephropathy group. They had higher risk for development of diabetes. An imminent risk of development of diabetes was in these 2 groups, where insulin sensitivity was moderately low and insulin secretion was low, and fatty liver group, which I showed you. And high mortality was seen in this group, high risk all-cause mortality was seen in high-risk visceral fat nephropathy group, where fat is mostly located in the renal sinus. So these are the various phenotypes which we have to see, but any of classification requires money and equipment. Gestational diabetes is something which is important to know. And if you see this, development of diabetes after gestational diabetes, cumulative incidence is very, very fast and high during 10 years of follow-up, and after which it stabilizes. And in India, it is particularly high. A study of 267 women at median of 20 months after the delivery. Dysglycemia was found in 57% of patients, diabetes in 10%, and prediabetes in 47%. So Indian women are at higher risk for development of gestational diabetes, and this is a particularly high group. If sugar is rising a little bit, it is going to rise to diabetes, certainly after some time. There are other factors also. Family history of diabetes, type of prediabetes, more difficult to regress with IFG, and conversion rate was lower in subjects with low than high BMI, which I showed you in earlier slides. There are a number of factors where not much is known. One is pancreatic fat, which we have been researching for quite some time. This is our study where you see left side a pancreatic outline, which has been shown from MRI study, and a volume is 47.6. Right side, smaller pancreas, 45. This guy is diabetic, although BMI is not much, and this guy is non-diabetic. Pancreatic fat alone may be a feature of type 2 diabetes, and if we decrease pancreatic fat, it may lead to regression. Now look at this study which was done in 2011, based on which several protocols for reversal of diabetes were developed. 11 patients, only 600 kilocalorie diet, reversal of fasting blood glucose to normal within first week of 8 weeks. Hepatic triglyceride content decreased from 12.8 to 2.9%. And pancreatic fat decreased from 8% to 6, just 2% decrease in pancreatic fat. So all this possibly contributed to reversal of diabetes. Hence, pancreatic fat may be an important factor, and we are looking at that. Low insulin secretive genotype. Again, there are a number of studies like genetic factors associated with low insulin secretion, and a recent study in Cell Reports in 2020 where these authors metabolically phenotyped and also looked at their pancreatic cells because pancreatectomy was done in these patients and impaired glucose tolerance. It was seen that insulin secretion first phase was down, which is well known, but beta cell mass is not different from patients with diabetes. So we earlier showed that beta cell mass may be different in this particular study in Caucasian people. In pre-diabetes and diabetes, beta cell mass is similar. Now, there are some other fat deposition like dorsocervical and chin fat deposition. Now, look at this particular phenotype, familial partial lipodystrophy, and look at this female, where the fat is absent from arms and legs, but more fat is present under the chin. This is double chin. This is the autosomal dominant phenotype and with associated with early diabetes, and this is caused by Lemon AC mutation. Now, there are several phenotypes which we see in normal people who do not have this mutation. Double chin is seen often, and also a buffalo hump-like picture similar to Cushing syndrome or HIV-associated lipodystrophy is also seen. And we previously showed that this is associated with insulin resistance, metabolic syndrome, and pre-diabetes also. This is another phenotype which needs to be discussed, which needs to be researched more. And this is another patient you can see, a patient with a marked buffalo hump, marked acanthosis nigricans. This patient has been pre-diabetes. Another factor is low muscle mass. Now, this is particularly prevalent in Indian population, along with excess body fat. Now, this sort of thing is related to, at least muscle mass is related to a mutation in the gene called myostatin. And look at this NEGM paper, a myostatin gene mutation in a newborn where muscles are so big like Hercules. This is the little Hercules. Look at the muscle in the thigh versus in this particular patient versus the normal newborn, double the size. Mutation increased the muscle size. We looked at myostatin mutation and we published in PLOS One, and we found that a polymorphism of myostatin mutation, polymorphism of myostatin gene led to decrease in the muscle mass and increase in the fat. Now, this phenotype again may be difficult and associated with this glycemia because muscle mass needs to be increased and body fat needs to be decreased. And finally, low vitamin D. Everybody is talking about vitamin D, whether it's a COVID-19 or diabetes. And Indians, 80 to 90% have low vitamin D. Is it related to glycemia? There are a number of studies. Randomized controlled trials in countries other than India. You see, most of the studies have not shown any association. This is one of the largest studies. And randomized controlled trials in India, this is our study on the top, the longest study, the largest study, and shows positive association apart from other studies also. This was published in PLOS One, 78-week randomized placebo-controlled trial, which showed that supplementation of vitamin D for 18 months led to decrease in the pre-diabetes to the significant degree, whether it's fasting blood glucose, impaired fasting glucose, or impaired glucose tolerance is concerned. So I summarize my presentation. Pre-diabetes is an important intermediate condition which identifies those at risk for diabetes and also for coronary artery disease. It is common in Asian Indians and increasingly common, and conversion to diabetes is faster than in whites. Identification of difficult phenotypes which may impede conversion of pre-diabetes to normal glucose regulation is important for application of aggressive lifestyle and medical therapy. Amongst these important are age, quick remission of uh, pre-diabetes with lifestyle measures, and presence of non-alcoholic fatty liver disease. More research is needed on several proposed phenotypes, for example, excess pancreatic fat, low muscle mass, and other genotypes. Thank you.